Hello, this PowerPoint presentation will be on pain management in patients with cancer. So what are the barriers to treating cancer pain? Patient concerns. They're concerned about not being a good patient. I think that runs across different types of patients. They come in, they forget their questions, they just say yes to whatever medications they're given, even if they don't really believe they need it, or sometimes they end up getting a duplicate medication. They have reluctance to taking pain meds. They fear addiction or the thought of being an addict. And that's something we really have to work on with cancer patients, that we are not concerned with them getting an addiction to their medications at this point. They worry about unmanageable side effects because they've had enough side effects with their chemotherapy. They're concerned about becoming tolerant to pain meds so that they don't work, so they don't want to start them until their pain is excruciating at some times. Then they have the inability to pay for treatment because treatment, we know, for cancer is extremely expensive, and they don't want any more expenses for themselves or their families. What's the barrier with healthcare system? There's a low priority given to cancer pain management. There's inadequate reimbursement or coverage of medications. The restrictive regulation of controlled substances. So cancer patients are lumped in with other patients, unless, of course, they're in hospice, where then they take care of the management. And treatment often is unavailable or access is limited. What are the barriers to healthcare professionals? They have inadequate knowledge of pain management and how to manage the patient with severe pain. They do a poor assessment of their pain. They don't assess usually frequently enough. They fear patient addiction, even with a patient that could be terminal. They're concerned about side effects of analgesia, so they were afraid of respiratory depression with these patients. They're concerned about tolerance to analgesics, barriers related to the patients. They're worried about resistance to report pain, so that they're not adequately helping them in the first place. They fear distracting healthcare providers from treating the cancer by thinking that the pain must be some gauge to measure what's going on with the cancer. They fear that pain means that the cancer is worse. So those two really go together. So what's the drug therapy for these patients? You have non-opioid analgesics such as NSAIDs and acetaminophen. You have opioid analgesics such as hydrocodone, fentanyl, and morphine. And then you have adjunctive analgesics such as amitriptyline, carbamazepine, and dextroamphetamines. The World Health Organization has an analgesic ladder. In step 1, that's mild to moderate pain, where you could use non-opioid analgesics such as NSAIDs and acetaminophen. Step 2, it's for more severe pain, where you will add an opiate or analgesic such as hydrocodone or oxycodone or hydrocodone. And then with severe pain, you're going to substitute a powerful opioid such as morphine or fentanyl. What are the principles for pain therapy for cancer pain? You need a comprehensive pre-treatment assessment to assess that and identify the pain intensity and the underlying cause. You want to individualize the treatment plan. It is definitely not one treatment plan fits every patient. You want to use the analgesic ladder and any other cancer guidelines for pain management to help guide you. You want to use oral therapy whenever possible for these patients. You want to avoid intramuscular injections whenever possible. You want to, with persistent pain, You want to provide a fixed schedule around the clock, not just when the patient is awake so that they will wake up in pain in the middle of the night. You want to provide additional rescue short acting for that breakthrough pain that occurs, because that breakthrough pain can be very disruptive to the sleep and the rest, and those are very important for a patient going through cancer and chemotherapy. And you want to evaluate the patient frequently for their pain relief and for their side effects. So your non-opioid analgesics include NSAIDs, such as aspirin and ibuprofen. They can provide relief as well as reduce inflammation and fever. But you do have to watch out for gastric ulceration. So you want to make sure, if the patient doesn't have any problems, that they are eating, uh, that they have something on their stomachs when they take this medication. If they do have problems, then you'll have to assess to see if they can even tolerate them, even if they do eat with the medications or take some kind of GI med. You have to watch for acute renal failure and bleeding, so you must do labs on a regular basis or have access to the labs that the patient's oncologist is drawing to make sure that their liver function is sufficient. You may have to adjust doses, or you may have to stop medication if there's a big problem. And with the NSAIDs, you have to watch for any thrombotic episodes that could occur, such as MI or stroke. This does not pertain to aspirin, which of course would help that situation. And they do not cause, of course, any kind of tolerance, dependence, physical or psychological. You also have in the NSAID group, they work because they inhibit the cyclooxygenase, or the COX 1 and 2. Most inhibit both 1 and 2, but some are selective for COX 2, such as the Celebrex. Celebrex can be a choice if there's more GI issues, because it will help to lessen those side effects. And there's also the threat of thrombocytopenia. With acetaminophen, Tylenol, it inhibits the COX in the central nervous system, but not peripherally. So if you combine acetaminophen with an opioid, you can get better analgesia than with acetaminophen alone. It does not have any anti-inflammatory effects. It does not inhibit platelet aggregation, but it does help with any gastric ulceration. It does not affect the kidneys or any thrombotic events. But you do have to watch it with alcohol because of the potential fatal liver damage, because acetaminophen is metabolized through the liver. And watch it with warfarin because it still can increase the risk of bleeding. Then you have your opiate analgesics, which we've talked about in the previous slides. So you do have to watch, they are for pain relief. You do have to watch for tolerance and physical dependence. There is the risk of addiction. But with these cancer patients, you definitely, that is not your first concern. So it's more important to select the right drug and to base dose on an individual basis. You prefer the pure opioid agonists for your cancer patients. You can rotate the opioids, but remember that you do want to have some preparations for breakthrough pain, which we're going to talk about next. Dosing should always be individualized. You want to use with caution if you're also using methadone or any of the meds that are classified for moderate to severe category of pain relief. And you do want to avoid the use of Demerol. One of the issues with Demerol, of course, is that it's short acting. For For your managing your breakthrough pain, patients may experience that with their monitored severe pain. Um, they should have access to a rescue medication. You want something that comes on quickly and doesn't not have to last long, because you would have the patient on their other meds. You could use an immediately release oral morphine. You could use a mucosal uh, fentanyl, or the fentanyl nasal spray. You want to watch for side effects. So you're watching for respiratory depression, so you would always have some Narcan on hand. You watch for your constipation, so you'll have your stool softeners, your laxatives, and then your antagonists that are um, for opiate use, constipation. Then you want to watch for sedation. You want to watch for central nervous system stimulation um, with caffeine and any of the other stimulants such as methylphenidate um, or dexamphetamines or modafinil. For nausea and vomiting, you want to make sure you provide an antiemetic or serotonin agonist such as Zofran. Other side effects, if there's itching, you can give them Benadryl. Watch for urinary retention, orthostatic hypotension, and neurotoxicity. For adjunctive analgesics, you want to use something to complement the opiate, not to substitute it. Um, you want to help with manage concurrent symptoms that exacerbate the pain, and you want to treat side effects caused by the opioids. So you're looking at tricyclic antidepressants, Elavil, and Elavil in lower doses can just be used as a mild analgesic and as a for sleep. You may use bupropion, duloxetine, venlafaxine, which have some properties for anxiety. Um, the duloxetine also has indications for neuropathic pain. You may need to use anti-seizure drugs such as Tegretol or Neurontin, again for neuropathic pain symptoms. Local analgesics could be used also, as well as antidysrhythmics. You could consider using central nervous system stimulants if the patient is not arousable enough, with some dexamphetamine, some dexedrine, which is short acting, or some methylphenidate with Ritalin, which would also be short acting. And those drugs do not work on a cumulative effect, so you can give them, and when you don't need them, you don't need to give them. You also could consider corticosteroids and bisphosphonates if for any bone issues and bone pain. Physical and psychological interventions, you can look at heat, cold, massage, exercise, acupuncture, or the transcutaneous electrical nerve stimulation, TENS. For psychosocial interventions, relaxation, imagery, cognitive distraction, and peer group support can also be very important. What about pain management in special populations? With the older adults, you have heightened drug sensitivity. You often have undertreatment of pain because providers are worried about addiction, tolerance to the meds. You have misconceptions with the elderly that they are insensitive to pain, that they can tolerate it better, and that they are more sensitive to opiate side effects. Um, they do have increased risk of side effects with the respiratory depression and adverse reactions, but they should still be treated well for their pain. In young children, they frequently experience more pain from chemotherapy and other interventions than from the cancer itself. So you have to be aware of that and how you need to treat them. So that's why it's important to know the underlying cause. And then the opiate abuser, you must, um, you have to set aside their history of abuse, and it's still our duty to relieve their pain. Um, but to be knowledgeable of when the patient just wants to be high and not really is not in that much pain at that time. So your general education for these patients is to um, teach them about the nature and causes of their pain, the importance of honest self-reporting, especially so they're not undertreated or they're abusing. What are the plans for drug and drug therapy? Um, Talk to them about what tolerance is, physical dependence and addiction, and fear, and what the side effects are, so they don't fear severe side effects, and what are the non-drug therapies that are available to them. So question 1, if a patient has a pain of 8 out of 10, which medication would you prescribe? And the answer would be C. You would do Dilaudid, the hydromorphone, because that's considered severe pain. The other ones there, if you use the WHO steps, would only be for mild pain, and you are discouraged from using meperidine. Next question, the patient is being discharged home with a prescription for opiates to control pain. Which statement indicates teaching has been effective? And the answer would be C. If the drug no longer works, the dose can be increased, because we want to keep the patient as much as possible pain-free. There can be a tolerance to the dose, but that doesn't mean that we're going to undertreat the patient. And last question, the patient is caring for a patient with bone cancer who is an opiate abuser. The patient states he has bone pain that is an 8 out of 10. What drug should be ordered that would be most effective? And the answer would be B. You want to give adequate doses of opioids. Even though they have abused in the past, you do not discount their pain with their cancer as long as it seems appropriate. So you would give adequate doses at regular schedules. You wouldn't increase the frequency necessarily, because that could promote their starting to abuse. The non-steroidals will not work, especially for bone pain, and the opioid antagonist, you want the patient to get pain relief. If you give that, they won't get any effect from their opioid. And that is it for this presentation. Thank you.